Good morning to everybody. I would like to thank the organization for the invitation. It is always a pleasure being back here in Bangladesh to share experience with you. Now, I'll try to summarize what we are generally doing in bifurcation lesions. Okay. So, the keys for success in bifurcation intervention is to keep it as simple as possible, to plan the procedure accordingly to complexity of bifurcation lesion. Whatever is the strategy, stepwise approach. Intravascular guidance is highly recommended, as we have seen in the live case. Lesion preparation, stenting, and optimization. So these are the steps in the bifurcation intervention. Intravascular guidance, I think we all agree that is very important and sometimes can change your strategy or can also give you the possibility to see something that on angio you cannot see, as well as lesion characteristics and preparation are having a key role in the procedure success. And we know that we have several devices to prepare the lesion as better as we can. On the other hand, we have evolution of strategies for the bifurcation lesion interventions. And what is different at the present time is that we have different platforms with different designs, more appropriate stress thickness and more conformable to the bifurcation interventions, more detailed data coming from bench testing and clinical practice, more use of intravascular imaging and procedure guidance, more effective devices for calcified lesion preparation, that means debulking, and improvement in basic strategies, more criteria to define simple and complex bifurcation, even if we do not have yet a universal definition of what is complex and what is simple. And of course, we have more clinical data with improved outcome. We have learned a lot of lessons coming from bench testing, how to do optimally bifurcation stenting, particularly when you are using two stents. And these are the strategies we are using in clinical practice. That means simple stenting, provisional stenting, which is used in almost 80% of what we are doing every day in our cath labs, and complex stenting, including at least three families, the T family with T stenting modified, TAP, and so on, culotte stenting, mini culotte, DK culotte, and crush family, which is mainly today mini crush or DK crush. And of course, provisional simple or two stents complex stenting strategy selection depends on size, length, and distribution of side branch. That means clinical relevance of side branch, lesion severity and lesion length on side branch, and anatomical complexity of side branch. That means disease extension, multiple bifurcation, also on side branch, the angle, the presence calcification. But do we have universal definition of what is complex and what is simple? I think no, because Medina classification gives us a good idea about the distribution of plaque, but the characteristics of plaque are still lacking in this classification. We have definition criteria which might help more in distinguishing between what is complex and what is simple. And if we look on the outcome depending on the selection, depending on what we have mentioned before, that means on Medina classification, you can see that EBCA main trial have shown that one or two stents will do the same. That means we'll have the same outcome, and at least at 1 year and 3 years outcome, target lesion revascularization will be even less with using single stenting. But we should remember that EBC main trial included patients with simple bifurcation with lesion length, mean lesion length on side branch was less than 10 millimeters. If we look on definition study based on different criteria, major criteria and minor criteria, I do not want to go through in, but just to show you that if you have more criteria to characterize the plaque, you might have different outcomes. Like in definition 1, you see that double stenting technique in simple bifurcation is doing worse than simple stenting, that provisional stenting. But if we look on complex bifurcation defined by definition criteria, then 2 stents in complex bifurcation will have significantly better outcome with the 2 stents as compared with single stenting. And this was confirmed also in definition 2 study, showing that in complex stenting is doing better in complex bifurcation than a provisional stenting. Now, what is important is the clinical relevance of side branch. Of course, in every bifurcation you are treated. If you have a small side branch, I think it is enough to keep it open and you do not choose any other strategy. And if it is not, if it is important, like that mean size is more than 2.5 and length more than 7 centimeters, then it's covering more than 10% of left ventricular mass, then I think you have to care about and you have to select your strategy accordingly to the anatomy and the characteristics of the bifurcation. Of course, side branch size does matter also, as we mentioned before. The angle does matter also. And length of lesion on side branch, I think it is very important. And this is coming from this meta-analysis showing that if we are dealing with side branch lesion less than 10 millimeters, then there is no difference between provisional and double stenting. But double stenting is doing better if you have side branch lesion more than 10 millimeters. Just a very quick example of how to do provisional and complex bifurcation. I know that next presentation will go in depth at least in complex bifurcation. Then just to show that also in provisional stenting, I think IVUS can help you in confirming your selection of strategy. That means characterizing the plaque you are treating. And then you have to go in step-by-step wiring, main vessel stenting, pre-dilatation, main vessel stenting, and POT, that means proximal optimization. And if you have a good result, no compromise of side branch, your procedure finishing here. And this will be the final angio and the final IVUS as well. But it does not going like this every time. In 20% of cases, can shift to shift to 2-stent technique, as coming from also EBC main study. And the mechanism of shift can be coronary shifting, plaque shifting, dissection, and SPAS. And I think mostly dissection and extension of dissection can can obligate you to shift from single stenting to double stent. And then you have to complete, again, if you have some compromise, in another step, that means recrossing distally, doing kissing balloon, and repot. two stent strategies, I think these are the families we are using today. And I'm sure that good angiographic and intravascular imaging can be obtained with all. My final slides, asking, do we have a gold standard strategy of double stenting technique? What is coming from this recent multi-analysis, the meta-analysis comparing provisional stenting to what we are using today, the different double stenting technique, showing that each strategy of double stenting have pros and contras, as you can see in terms of single endpoints. That means some will have more death or cardiac death or MACE or target lesion revascularization or target facet revascularization or stent thrombosis. But I think we can summarize that in bifurcation lesion, clinical relevance is a crucial point in order to select whether you have to go for bifurcation stenting or just keep it open. If not relevant, then keep it open. If it is simple, accordingly to what we have mentioned before, then elective simple stenting. If it is complex, then complex stenting. That means elective complex stenting from the beginning. So intravascular imaging always recommended for procedural planning, guidance, and optimization. And the take-home message was that optimal upfront strategy is still provisional stenting in the majority of patients. However, nearly 20% of cases will shift to two-stent strategy. All two-stent strategies have their pros and contras. Optimal one is that well-performed and optimized. In all strategies, no doubt, no discussion that you need good experience, stepwise approach, planning the procedure accordingly to lesion complexity and lesion preparation and optimization. Finally, I think it is essential to have a good experience in more than one two-stent strategy to be ready for Plan B, which might be necessary during your procedure. Thank you very much for your attention.
Thank you, Dr. Sheiban.